Actually, we wrote a paper, I just realized. It's called Death in Bodybuilders.
I was in college, and I was doing health and human performance, was my bachelor's, and the teacher was talking about protein intake. And I raised my hand, and I was like, that's incorrect. That's not near enough protein. And we got into an argument in the class, so I didn't go back to her class. Some other students in the class came to me like a week later. They found me somewhere on campus. They're like, hey, man, you got to come back to class. She wants to apologize to you.
Oh.
I'm serious.
Did you go back?
I did.
Did she apologize?
She did.
Larry, let me ask you, in your clinical experience, because how long have you been prescribing these peptides for?
I don't know, 3 to 5 years, maybe.
Would you say you have hundreds of patients on these peptides?
Yes.
Have you seen a side effect from these peptides that concerns you?
The only side effect I've ever seen is something at the injection site from an allergy.
Yeah.
I have never had a systemic problem.
That was a profound comment that you said. Think about the medications that we use that are FDA approved. Would you say that side effects or more severe side effects with some of those medications are more concerning than with peptides?
Yes.
I think that's profound because from a healthcare provider's perspective, I'm interested in offering these peptides to my patients for the reasons that we've discussed. But how do I know if they're being sourced correctly? How do I know that they're not going to be contaminated?
We actually hired a in-house compliance officer who was an ex-state board inspector. So she looks at everything. Everything that we do, we hire people that are smarter than us in certain fields that protect us and protect our patients.
Welcome to Fertility and Other F Words, the webcast that tackles fertility, sexual health, and everything in between. No topic too taboo and no question off limits. I'm Dr. Amy Pearlman, board-certified urologist with expertise in sexual, hormonal, and genitourinary health and co-founder of Prime Institute in Miami, Florida.
I'm Dr. Larry Lipshultz, a professor of urology, Baylor College of Medicine. I am a board-certified urologist and director of Baylor's Division of Male Reproductive Medicine and Surgery.
All right, Larry, I know you've been busy as always. So what's something that's happened that's interesting recently in clinic?
Yeah, so I thought I'd share this specific case, but I wanted to recap the fact that we do talk about cases related to either erectile dysfunction, low testosterone, or male fertility. So this, we're talking about an infertile couple.
Okay.
They came to me, they were both 41 years of age. They had been trying to initiate a pregnancy for about 8 years. They did undergo IUI for 3 or 4 cycles in 2021. They did get a conception, but they had a miscarriage or an abortion at 14 weeks. Since then, they've tried IVF multiple times. And what seems to be the problem, going to 2 different centers, is she does produce anywhere from 3 eggs to 10 eggs. They have a poor fertilization rate, and what does fertilize doesn't make it to blastocysts. It arrests. So what's going on here? Well, we looked at his hormones, relatively normal. We look at his sperm density. It goes anywhere from 4 million to 26 million. This was in 2021.
Yeah.
Now it's trending down. He's averaging now about 4 to 5 million with 60 to 70% motility.
So let me ask you this. Do you ever take one semen analysis result and say, this is what's going on?
Never.
Tell me why.
Because men differ. They vary.
Yeah. You just mentioned from 4 million to 28 million. That's a huge variability.
Big difference. But it was over the course of 4 years.
Yeah,
so
okay.
there could have been intervening illnesses or something that we don't know about. But sometimes when these cycles fail for no apparent reason, we say, well, maybe something's happening after the sperm leave the testicle, and we do an office testicular sperm extraction, which we did in this man. They went through IVF again, and no good outcomes. So we're dealing with a couple in whom the man has a lowish count, they don't have high fertilization rates, and they do not make good blastocysts. So what's going on here? What do you think is going on here?
Have you done whole genome sequencing in him?
It was normal. So I'll tell you where the issue is.
Yeah.
They're both 41.
Yeah.
And we know we deal with advanced maternal age, but now we're talking about advanced paternal age as being an issue. And Mike Eisenberg out of Stanford has made this kind of his new focus of research.
And you trained Mike Eisenberg.
I did. And he published a paper that has yet to come out, I don't think, in mass publication, but it did come out in the Stanford publication that it was where he works. And it was a very large group of patients.
Yeah.
It was
40 million.
Yeah.
They looked at over 40 million
40
U.S.
million.
births.
And But what concerns me, though, is he states in the beginning that he's defining it as over 35.
For advanced maternal age, which was younger than I would have thought.
Yes, because when he cites studies looking at abnormal outcomes, 45 and 50 years old. So to me, I use it as over 50. That's kind of my personal.
So you would define advanced maternal age as over 50.
Yes, and I've always done that. And I don't know. When I see him, I'm going to find out why they picked 35 to look at. So I did something kind of, I don't know. I guess it's okay. I went to Open Evidence. Do you use that?
I do.
And it's a good review AI because they only use the JAMA and New England Journal. And I got two different answers. So the first answer,
What did you ask it?
I said something about in a couple where both the male and female are 41 with poor fertility and poor blastocyst production, and a man with an average sperm density of 4 to 5 million, what do you think are the possible reasons? And the first time they said, the most likely reason is the combination of low sperm concentration, parentheses, severe oligospermia, and advanced paternal age. Nothing about women. I thought that was kind of strange. She's 41. And I asked it again, and this time it said, advanced maternal age at 41 years profoundly impairs oocyte quality, fertilization rates, and blastocyst development.
Yeah.
So, So
one focused on it being a male problem and the other focused it on being a female problem.
Right. There is one where they said, they also say the synergistic effect of both partners being 41 years creates a particularly challenging scenario. But they don't go into detail this time. They did the last time. But I think this is a problem we're going to see more often because we're starting to see more of these patients coming in, certainly with the woman being older because they're postponing having children. And now we're seeing the men coming in being older. And the question is, we know that women are now pushing towards freezing their eggs earlier on. It's becoming more and more popular, especially professional women who have a full-time job and don't want to have a child right then and there. But should men be freezing sperm prophylactically? What do you think?
Oh, I think it's a great question. I offer my patients who are, let's say they have some hormone issues, I offer them all sperm cryopreservation. Because they could say no.
Right.
Now, usually if they're very young, like in their mid-20s and having a child is nowhere on their radar, they'll decline that offer. Right. But I think a lot of people think that freezing sperm is way more expensive than it actually is. I mean, I send patients to University of Miami and it ends up being a couple $100s to do like the sperm cryopreservation. And then it's a couple $100 every year for storage.
Yeah. And that's the same thing at Baylor. Except at Baylor, they always forget to send out the yearly bill. So it's really a good deal. You get away with something.
I think it's something we should offer people.
Yeah, I do too. I don't.
Yeah.
But, I am going to start. I've, read this a little bit more about paternal age. Mike's coming to town to be our visiting professor, and this is a topic he's going to address. So I'm going to be interesting to see actually how he actually presents the data.
Yeah. And what's interesting too, and I don't know if you have the same sort of demographic or situation that I do in Miami, but like this past week I saw a guy, he's 61, his wife is in her early 40s, and he was coming in for maybe ED. And I just asked as part of that conversation, like, do you have any kids? And he said, no, but we really want to have a kid, right? And at 61, he's definitely advanced paternal age. And so you would actually send me this article, like right as like the day before I was going to see this guy. So
really?
I actually pulled over the article and I said, you are advanced paternal age. And I just want to talk to you about what some of the risks are. She's early 40s.
Yeah. So that combination is not good.
Right. So
especially for autism.
Yeah. Preterm. Low birth weight.
Yes. But I mean, the autism thing scares me.
Yeah. Yeah. So I think that's also, it's something we need to educate more guys about. But I'm seeing a lot of guys who are older that get together with younger women, especially in Miami. Do you see that a lot in Houston?
Yes.
Yeah.
And I think the other thing is, if you're going to offer them sperm banking, do you have to at the same time say, but if you're going to use it effectively in the future, most likely you should be considering IVF because they're going to have a finite quantity of sperm. So one thing I have them do is I do have them divide up the sample into multiple straws, they're frozen in straws, so that they don't have to thaw the whole thing just to do it one cycle.
Yeah.
So that maybe you want to speak to your
banking.
Well,
they put it in multiple vials. Yeah. That's a great point.
And they put the vials in different tanks. So if there's a burnout in one of the tanks or a meltdown,
Yeah.
you still have your sperm.
Yeah. Yeah. So I want to tell you about a patient that I recently saw. He's in his mid-40s, and he came to see me, actually, and my sister, because he wants to get healthier. Prior to him seeing
And what
us,
does your sister do?
so she's a gastroenterologist and does medical weight management, but also counsels people on nutrition and exercise. And he's already lost significant weight. He had lost about 70 pounds even prior to seeing us. As part of his full evaluation, I checked his hormone panel, and I was expecting his testosterone actually to be on the lower side. And his testosterone level was well in the normal range. His total T level was in the 800s.
Oh, that's great.
That's great, right? And I checked his IGF-1 level, and I actually started checking IGF-1 levels after you and I have had some conversations, right? And he has a normal IGF-1 level that stands for insulin growth factor.
Which is a surrogate marker for growth hormone.
Okay, yeah, so I'm glad you made that important point. So he saw my sister about a month prior, and just with nutrition and exercise changes alone, so he hired a trainer, he's really focusing on his protein, he lost 4 pounds and gained a pound of muscle, which is amazing.
Yeah.
And that was just in about 4 weeks. And even during that time, it was the holidays. So usually people put on weight during the holidays. And what he said was, I appreciate your clinic and your advice because you're not throwing a bunch of medications at me, right? But that begs the question for this guy who's like feeling pretty well, where lifestyle modification is making great changes for him thus far, is there a role for peptides?
For what? So, I mean, if you're going to offer a medication, you have to address the problem you're solving.
Yeah.
So what problem would you be treating?
Well, I think that's a great question, right? So I think if this guy were to see people in 5 different clinics, he would be offered 5 different options of therapies, right?
Why? But why?
Why?
Why are we treating?
Well, I think he's coming in and he wants to feel the best that he can.
Right.
Right?
Right.
So from my perspective, I'm like, you're doing amazing. Your testosterone level is normal. Keep doing what you're doing and let's reassess.
Exactly.
And so he's happy with that, right?
I mean, with every medication you give is the caveat that it may not work and it might make you worse.
Right.
So that's not true for all medicines.
Yeah.
But some of them can just make you worse.
Yeah. But let's say this guy says, okay, yes, I've gained a pound of muscle. I hired a trainer, but I would like to recover better because I'm going to the gym and I'm feeling quite sore after I'm working out.
Well, that's different. Then you're treating his post-workout soreness and aiming for a faster recovery. And we do know that BPC TB500, a combination of 2 medications that are peptides that are quite synergistic, that would be an option for him.
Yeah.
You have to be careful with the IGF-1 though, because you're only going to treat if it's really, really low. And what are you going to give him?
Like if his IGF-1 were really, really low?
Yeah, which is a surrogate marker for growth hormone. So what we're saying is
I'm not going to treat him with growth hormone.
your growth hormone's low.
Right.
So we'll try to give him something that'll stimulate his own growth hormone release. So that would be reasonable. But I don't know. I just think someone just wants to feel his best, you got to be careful. The enemy of good is better. So he's good.
Yeah.
So, I mean, I don't know. I probably wouldn't do anything.
Yeah. Well, I like that approach. And I think we have a very similar approach there. But again, if you ask 5 different people, 5 different clinics,
and some
they're
people
say,
feel like they have to give them something.
Right.
Especially if they're selling it from the office.
Right.
So.
Yeah. So let me ask you this, though, because you mentioned that you do check IGF-1 levels in a lot of patients, especially if they're considering peptide therapy.
Right.
So have you found that people who even have a normal IGF-1 level benefit from something like a growth hormone secretagogue?
Well, so once again, we're dealing with normal ranges.
Yeah.
And if you think it's bad for testosterone, it's worse for growth hormone. So, what's good? I mean, I don't know. We like it to be, I guess, above 300. Most people come in the 200s, 250. So I would expect it to go above 300 if I give them something.
Yeah. So you're not strict about it?
No.
Okay. But then are you checking IGF-1 levels
Yes.
on follow-up? And what does that tell you?
Whether or not what he got is real.
Uh-huh.
But I don't have a target. I just want it to be higher.
Okay. All right. Excellent.
Okay. So let me know how your man does.
Okay. Sounds good. All right, let's get into today's episode. So I am thrilled to introduce our remarkable guest today, Rick Manuel.
Rick is one of the owners of Optimal Balance Pharmacy and the sole owner of Houston Regenerative Consultants. He works with physicians around the world, educating them on evidence-based protocols in peptides and regenerative medicine. Rick partners closely with clinics to help match the right therapies to the right patients, with a strong emphasis on safety, appropriate dosing, and clinical outcomes, particularly in musculoskeletal and aesthetic applications. So, Rick, thank you very much for coming.
Yes, sir.
We appreciate you taking the time out. I know you're busy to come here and talk to us today. And for our relationship, we go back to 2011. You were then managing the gym that I was going to. And since then, your career has skyrocketed. You're now also president. Are you president of the company with the stem cells?
Yeah, I'm a vice president of sales nationwide and some international for 3 different collaborations of stem cell companies.
Right.
Yeah.
And the reason we're particularly excited about having you today is because you also are co-owner of a very productive pharmacy, compounding pharmacy, from which we get a lot of our peptides. And we're going to get into that today as our discussion progresses. But again, thank you very much for coming.
Yeah, thank you for inviting me.
Now,
Amy,
Rick,
did
I have
you
a
want to
question.
start out? I know
I do have a question.
I know you have a
for
question.
Rick. So when you guys were working out at the same gym together, you were
Oh, wait,
managing
a
that
gym question? I
Yeah. Was he crushing it?
He was there all the time.
He was there. He was present.
And listen, showing up is half the thing.
Okay, you're right.
He had his personal trainer, so
Yeah.
he was doing what he needed to be doing.
Yeah.
Right.
Yeah.
We didn't train together,
Yeah.
so I don't know exactly what he was doing, but he was there, and that's all that mattered.
I
love
always
that.
showed up.
Yeah.
And I always did what he told me.
I love that.
There you go.
Yeah.
And I still do.
Yeah.
So,
Yeah, I mean, you work out with a trainer a couple times a week, right?
Yes.
Yeah, I love that.
yeah.
Used to working out with Danny, right?
Yes. You have great memory. Yes. And he's doing very well. That's my trainer.
Yeah.
Yeah, he's a nice guy. I like him a lot.
So I think it's important to, first of all, many people watching may not know what a peptide is. So how do you differentiate a peptide from a biologic?
It's the strand of it. So a peptide is a certain sequence of amino acids, right? Laid out linearly. If in there's a certain amount of amino acids, you get too many of them, it's considered a biologic, right?
Right. But who set the number at 40? I mean, you know what? That's the limit now. Above 40, they call it. I guess the FDA.
It used to. The FDA said it. It used to be much higher.
Yeah.
It used to be about 150 linked peptides or amino acids to be considered a biologic. What used to really, they didn't even term it that way. A biologic used to be something that came from natural matter, and now it's they kind of try to curtail that definition to be able to look at things and regulate things differently.
Yeah.
So it's all about their regulations.
Yeah, which is a blessing and a curse.
Right.
And we want the FDA to regulate.
Yeah.
But we don't want them to over-regulate
Yeah.
because then it gets into the arena where we can't write what we want to write.
So let me ask you, how did you get into this space? Because you were managing a gym. Now you're managing a stem cell, consulting company and peptides at a pharmacy. What's your background?
My background honestly started out as a personal trainer for years, and
So you're on the ground seeing what people need.
right,
Yeah.
exactly. And I started working in supplement shops in college, like GNC and things like that. So I would sit back there and be kind of bored, and I would just study. And I was interested in what makes the body work better. How can I perform the best? I was not the best salesperson because people would come into the store to buy certain things, and I wouldn't sell it to them because I would tell them this is not really. It's all hype.
Yeah.
They used to have a product that was a myostatin inhibitor. It had this big bull on the front. I forget the breed of bull. They were saying if you take this, you're going to have unlimited muscle production. Well, I knew it was. I looked at the ingredients. I could tell that none of that was going to do that, and so I wouldn't sell it to anybody. So I got in trouble by them.
Yeah.
So you were there in the era of SARMs,
Yeah.
which are terrible. So a
can you
SARM
talk a little bit more
is
about
a
that?
selective androgen receptor modulator as opposed to estrogen modulators, which we still use. But the SARMs would turn off the HPG axis. And the guys are coming in still, and they have irreversible changes, which I don't understand exactly.
And
but SARMs
liver
were
damage as well.
But this is what they were selling out of these stores,
Yeah.
storefronts, and promising, especially college guys,
Yeah.
high school kids, that they were going to get big by taking SARMs because it stimulated androgen receptors. But it was so non-selective that it was dangerous.
Yeah. Definitely.
Do you still see people that are on SARMs?
No, I don't see them on it, but I see them with the problems secondary to taking them.
Yeah, even after being off of them.
Yeah, for years, several years.
Interesting. Yeah.
I think those came about because there was so much negative connotations towards testosterone.
Yes.
Back then, right? And so people were like, well, let's figure out a way to boost people's testosterone without giving them testosterone.
Right.
And
But it
get around
didn't.
tests.
Yeah.
It didn't, and it caused a lot of damage, like
Yeah.
you mentioned.
Yeah.
What else did you learn from being in the supplement industry? We won't tell anyone.
No names.
No, I mean, just more or less where they're sourcing their ingredients from. Like you look at certain things. A lot of supplements out there are they have good marketing. But when you really look at what the base of them in there, it's the things in there, all these herbs don't turn on hormones the way they should, right? They're not designed that way. I always explain to people, if it's not from a human or a mammal source, those proteins, they're not going to signal the same way. Like you have people that use plant-based stem cells. Well, I always my joke is if you have a heart replacement, you don't use an artichoke heart, right? Because it's not the same thing.
I like that analogy.
You know, they don't work the same, so you're not going to get the same signaling. You have to have complete proteins. The body, everything in your body requires proteins to function. You need a certain amount of protein to initiate a response, and a lot of these supplements are underdosed, or they don't have enough of the complete array of proteins. Like the biggest thing that people sell is branched chain amino acids. Those are 3 amino acids. You actually need all 9 essential amino acids to stimulate mTOR properly and to leave it turned on. High leucine will turn it on, but it fades. You have to have all 9 essential amino acids to be able to sustain that pathway, and that's how you get, protein synthesis. You grow, you recover. So,
do most of the protein products that we buy, in the big jars, do they have the amino acids in them? Do they claim to have them in there?
They do. They have the essential amino acids and many more, but you have to look at what type of protein it is.
What's your favorite type of protein?
I like to use like an isolate protein, a whey isolate.
Because whey is high in leucine.
Yeah, but you have different forms of whey. You have whey concentrate, you have caseinate, which is a very slow responding protein. You have different forms of protein. And back in the day, people would just put blends of different proteins in there. Right. The whey isolate has the highest bioavailability, so it's going to absorb much better, be more productive. It doesn't taste as good, but it works better.
Okay, so you were in the supplement business, and then what happened?
I just decided I wanted to be a trainer. Like my first goal when I was younger, I was very strong in high school, not big, just strong. So I wanted to be a strength coach. And then I got into personal training, and that led me to moving to Houston in 2006, because where I came from in Lake Charles, Louisiana, people didn't value it as much. So they didn't value it as much.
Yeah. And they eat terribly.
Yeah.
Right?
Yeah, of course.
It's great food.
Yeah.
But it's not good for you.
Yeah, and it was more of the mindset of just lift and eat, lift and eat, lift and eat. Even they weren't focused on what they were eating necessarily, right? Just get the calories in. And I was part of that. And I moved to Houston and started just doing more research and learning that you have to have quality things coming in your body at all times to be able to be successful.
You've got to watch the episode with her sister Michelle, because she goes into all this, down to like almost the molecule.
Yeah. But it's really important, right? Everyone needs to know how to discuss nutrition, because when you were a personal trainer, you were interfacing with the patient or the person way more often than we ever would as their healthcare provider.
Yeah,
so everyone has to give like a consistent message. Otherwise, they get different messages. People get confused and they ignore all of them.
Yeah. I think the biggest thing in my field as I was a trainer is I would tell people, list everything that you like to eat, right? And then I'm going to take that list and I'm going to find the things that you can eat in this diet, instead of just telling them what to eat, because they'll never do it, right? If they don't like chicken, don't put chicken in their diet. Yeah. You find something else, right? And so I would just eliminate things rather than tell them what to do.
I love that approach.
And it helped them to kind of be able to do the diet that way.
Yeah,
for sure.
And they liked you better because you weren't taking away their foods, so to speak.
What were some of the other challenges that you faced when you were a personal trainer? Like, was there an extent to which you could help your clients?
Yeah, I mean, a lot of the clients would do what you asked them to do inside and outside the gym. They would all do what you wanted to inside the gym, because they're in front of you. Yeah. But I realized after a while, these people aren't listening. They're not going home. They're not eating the way I want them to. And I started to become frustrated, honestly. And so I started looking for something else to do to be able to help people. And that's when I kind of got in the medical field after a while and started working with a lot of doctors, including Dr. Lipshultz, for hormones and different things like that. And I always ask questions everywhere I go, because I'm always trying to learn. I'm definitely not the expert on anything. I have knowledge on a lot of things, but not the expert by any means on anything. But I just want to understand how things work. You tell me this does this, well, explain to me why it does this. Because the reason why it does something could be negative long term. We see this with some of these hormones that it shuts off pathways that can be dangerous down the road, depending on what you're doing, how much you're doing of them. Because I did competitive bodybuilding for a while after that, and so when you're doing that, you're putting things in your body that other people aren't, right? Lots of high dose hormones. And back then we didn't have the nice pharmacies that we work with now. So you were getting the stuff from wherever you could, right? You never know what you're putting in your body. You're just hoping that it's right, And that was a big problem.
I've been impressed by the fact that guys who are competitors in the bodybuilding space will almost take anything. I mean, I think their filter is like,
Yeah.
there is not there, right? I mean,
Yeah.
there's there's things that people take that I have never heard of. I don't know. So where do they get it from? They get it on the street.
Yeah. Well, let me ask you this. When a bodybuilder, tragically passes away, does that affect anyone? Like, are people like, oh my gosh, I know this guy was taking this, and that, and I should probably stop taking it? Or is it like, oh, that was sad, but I'm still going to take the risk of taking these therapies?
Yeah, unfortunately, the latter is true, right?
Yeah.
They're like, that's terrible that happened to him, but I'm going to keep doing that.
And there's this attitude that it's not going to happen to me.
Yeah. And what you see a lot of times is a lot of these bodybuilders that have passed away, it's actually not from like cardiovascular events. It's more the diuretics that they're taking will affect their kidneys to the point where, it limits their health and they get sick. Like Flex Wheeler was one of the top bodybuilders in the world. And he had such bad kidney damage from all these diuretics that he now has amputated legs.
Oh my goodness.
It's terrible.
Well, it's interesting you bring that up because on a prior episode when we were interviewing my sister, she competes in fitness competitions. And when she was initially training, she was like, I did it in such an unhealthy way. She was like, I think I gave myself like a compartment syndrome. I was
her
probably in
legs.
kidney failure for a couple weeks because I was taking so many diuretics.
Yeah. And the diuretics are not needed a lot of times. If you diet right and you do your cardio, you get the body fat down, you shouldn't have to manipulate things that much. The problem is they get the day before the show, they look at their body and they're holding a lot of water because their cortisol is elevated because they're stressed, they have anxiety, and so they take something to knock it down. But when you pull all the minerals out of your body as well, what these diuretics do, they don't just pull water. The muscles need those minerals, right? The muscles go flat, so to speak. I know that's a weird term for people that aren't in the bodybuilding community, but you've heard of the word getting a pump in the muscle, right? The blood flow and all that.
Amy
You can't
pumps
do that.
regularly. Seriously, she
Yeah.
goes to the gym almost every day.
I take my daily Cialis, if you're wondering.
But if you don't, but if
I don't
you're-
think that ever crossed his mind.
But if you don't have the proper mineral balance,
Yeah.
you won't get that same pump. You need your magnesium, you need your sodium, you need your potassium. You need those three specifically to be able to get the proper pump to pull the nutrients into the muscle.
It's interesting you mentioned about the kidney problem. So we wrote a paper, I just realized.
Yeah.
And it was called
You've written so many interesting
know.
papers. I
It's-
love
no,
it.
this one we have to talk about. I
Yeah.
have to pull it. It's called Death in Bodybuilders. And we got as many as we can from some registry that we had access to through a former bodybuilder who was interested in looking at this. He wrote it with us. And I don't remember how many guys we found. And kidney failure was quite up there on the cause of death. And I was taking care. Do you remember somebody named Nasser El Somebody? Yeah, so he was my patient. He was gigantic. I mean, 6'6", like 350 or...
He wasn't that tall. No, he was probably 6'1", maybe
Maybe
6
I was
foot.
shorter.
But he
looked
was
big to me.
340 pounds.
Yeah, he looked huge to me.
Yeah.
And he ended up dying of kidney failure in Europe. He stopped and stopped competing, went to Europe. He died in his 40s.
Oh, wow.
Yeah.
Yeah, he was a monster.
But what happened then, and is not happening now that I see as a plus, is people used to bulk up like 40, 50 pounds and then lose 40, 50 pounds to step on stage. And this yo-yo with their weight, I think was very bad for cardiovascular health.
Absolutely.
But they
I
don't
was
do
one of
that.
those people. I know.
But I don't see that much anymore. I think the guys
they're staying leaner.
They stay fit most of the time.
Because when you do that, you gain all that body fat and extra water and everything. To get it back down, you have to do so much cardio
Right.
that you end up wasting muscle.
Yes,
You lose
but
all
I
your
don't
leg
think
size.
we had the techniques then, like the InBody in your office that you have,
Yeah.
to actually look at muscle mass.
Yeah.
So people thought, well, I'm getting bigger, but they didn't
Yeah.
really have sophisticated ways of looking at what was going on inside.
Yeah. So, Rick, let me ask you this, because you alluded to the fact that you're a very curious person. And I think curiosity is one of the most amazing traits that someone could have. And you've been in a lot of different industries surrounding healthcare. So my question for you is, how do you determine, how do you find the evidence? Where are you learning from, right? And where does published research play a role, but also you as a patient, you working in the fitness industry, you in the supplement business, how do you kind of reconcile all of that information together?
You have to pull it from many, many sources,
Yeah.
right? A lot of the sources are trying to sell you something, right? So you have to be able to identify that right away. Like if you go and Google, what does this supplement do? The first 100 things that drop down are going to be somebody trying to sell you that supplement. A lot of things, if you want to really dig into like studies, they are hard to read sometimes, is to go to Google Scholar. right? And that's just nothing but studies there. They're not going to be specific to what you're looking for a lot of times, because these studies are very, very specific as what they're looking for. But you can kind of, extrapolate that data and kind of figure out that it would do what you want it to do. So I've just met really smart people over the years.
Yeah.
One of the PhDs I work with out of California is Dr. Rafael Gonzalez. He's been in stem cell research for like 27 years, and he's one of the best in the industry, and he understands how the body works, how these different mechanisms of actions occur from here to here to here. So honestly, I just bounce things off him a lot.
Yeah.
So he's been a mentor to you in this space?
Yeah, definitely. He's helped me to understand on the cellular level with stem cells and exosomes and NK cells and all these things that he really focuses on. By understanding that, how it works, it helped me to understand how peptides actually function in the body.
And that's important
Yeah.
to know the whys.
Right. And there are so many like data-free zones in this space that oftentimes I think what dictates what we might offer or not offer a patient is like, what did my friend tell me? What's been my own experience? I think that is the clinical and expert experience is almost just as valuable as a study, because even looking at a study, okay, that's in one population of people, which are like, it's like you're cherry picking the easiest patients that you think you can see some sort of benefit in, which is not the real world experience. And I think we have to put more value in what happens in a typical dude walking down the street. What's his experience?
Yeah,
Yeah,
exactly.
part of the problem with research in this area is the fact that most research is funded by big pharma.
Yeah.
I mean, even your NIH money is coming indirectly many of the times from big pharma,
Yeah.
and they're not interested right now in the areas that Rick's in.
Yeah.
They don't want to put the money up because they've got other things, the things you see on TV that we were talking about that they're advertising all over the place now. That's where they're making their money. And so for them to do a study on a particular peptide, is very, very costly. And then they have to come up with, well, how much are we going to be able to sell this peptide for to recoup our investment? And it's just not worth their money most of the time.
Yeah.
And the problem with that, with studies, is if you have a product that's not patentable, and you go through to go through a proper FDA-approved clinical trial takes anywhere from 3 to 10 years, $300 to $500 million, right? So
Right.
you have capital investors coming in. If this product is not patented and you get it approved, then everybody else can make it,
Right.
right? So you can't make your money back. And that's a lot of times why a lot of these peptides have been pulled out of studies, is because they weren't patentable, right? As the original ones that got approved by the FDA, they had the ability to patent them. They developed them, they patented them, they were smart about it. A lot of the other ones, they just created and didn't patent them. And so now there's no.
And many of them are naturally occurring in the body anyway,
Yeah.
and they're being
Is that why they're
purified.
not patentable?
Well, no, you just they create them.
Yeah.
And like there's one main peptide. I'm not going to say the name of it because I don't want to hurt this lady's reputation. But she created it and didn't put a patent on it. And Big Pharma took it and patented it, and we have a very popular drug today. She went back and recreated it through different amino acid chains that were very similar, and that's released now as well. So she learned her lesson, right? You have to, people with more money than you and more greed than you are going to take from you if you don't know what you're doing,
Yeah.
basically. And that's how this industry has gotten so, for lack of a better word, corrupt.
Yeah.
They're not really trying to cure people as much as they are trying to make money.
Yeah. Larry, let me ask you this question, because so much from like a healthcare provider standpoint when it comes to peptides is, well, there's a lack of research. You are one of the most well-published healthcare providers in the entire world. What are some
She's
of the
so nice.
I know. Thank you. What are some of the limitations of research?
Money,
Yeah.
and money.
Yeah.
Because, if you don't have the money, you can't hire people.
Right. And the
you
research
can't set up a
infrastructure.
lab.
Yeah.
I'm at an academic institution. You have to pay the IRB.
Yeah.
You have to go through an IRB. Everything is so examined under a microscope.
Yeah.
That, research is difficult, not just the doing the research.
Getting it
but
published.
and
Getting it published is very challenging these days. And
it
it's
is.
thousands of dollars to get something published.
Right.
And, I think like from my perspective, at the end of like every study, a retrospective study, it'll say we need randomized, placebo,
Right.
controlled
Everyone.
trials. And the
More
reality
evidence
is like,
needed for this conclusion.
yeah, I've been involved in randomized trials before, and they are so challenging to implement because when you're in a busy clinic, you can't do that. You can't be in a room with someone for 2 to 3 hours to sit down with them to make sure you're checking all the boxes on the questionnaire. And as much as we want to set up these great protocols, patients are not compliant. They don't show up for their follow-up visits. You don't get all the information you need. They are so challenging.
It's very, very challenging.
Yeah.
And I think that's why People don't do it. And if they do it, they're going in a direction clinically that's going to be profitable for your funding organization. People think that the NIH money is given because you've got a great grant or a great study. No, a lot of times it's because pharma is going through the NIH to fund your study so they can get the drug.
Yeah, exactly.
Or the technique.
Yeah, there's so many things we could get into there that we, shouldn't, I guess, but there's
But we
so
can.
many, there's so many negative things on the back end of that we see. I mean, we talked about earlier, like the drugs you see on TV that are marketed. One I brought up, the list of side effects included this basically will give you cancer and eventually kill you, right? And it was treating bipolarism.
Yeah, but it was probably two people walking on a beach, looking
holding
very
hands.
happy, holding hands.
Yeah, you didn't know what the drug was for until the last 2 seconds of the commercial. This treats bipolarism, and it shuts off, and you're like, wow, those people look happy for now. But they're gonna
And
die.
that's so interesting that he brings up these ads on television. Think back, 5 years ago, there weren't ads. Now, no matter what channel you turn on, if you're looking at TV, you're going to get advertisements.
Have you seen like the flash mob for like, the GLP-1s?
The what?
It's just like a bunch of people dancing.
Oh, yeah.
Like, really?
So are they all fat? No,
Not anymore. That's why they can dance.
no, I've been watching. They had really pretty good commercials for the GLPs.
It's a good jingle.
They had a series. Yes, it was, and they had a series as they went to a new commercial. They kept changing.
Yeah.
They were always heavy women.
Yeah.
Did you notice they were? Where were the heavy guys? They were like, I guess guys won't pay for it. They weren't advertising to the men.
Well,
No, they weren't.
women make up to 80% of the healthcare decisions for themselves and their loved ones. So I think a lot of that marketing is probably directed towards women who are making
But do you think
a
a
lot of
woman
those
ever
decisions.
turns to her husband and says, "Honey, you're fat"?
Yeah.
Probably.
And the husband's like,
Yeah.
cool, thanks. I'm still going to eat pizza.
It's like PHAT.
Men don't really want to take care of themselves. Well, it's changing now. The environment's changing. But I remember growing up, like, men didn't go to
But you grew
doctor.
up in
Men didn't do it.
Louisiana.
I did, right. I grew up in the country, but
But look what's happening with the growth of gyms.
yeah.
I mean, all over the place.
Yeah.
Expensive ones, not expensive
Yeah.
ones. It's amazing in the number of new gyms that are popping up.
Yeah.
And that's the number one way to make your body better, right?
Yeah.
Yeah.
Is to exercise.
And eating right.
Yeah, of course. Yeah, the food is number one. But without the resistance training, especially as we age, honestly, the older you get, the more you need to train with resistance training. You keep that muscle on. I mean, all the studies are showing now that the more muscle you have, as the older you get, the healthier you are.
Yeah, we talked about that yesterday. And to prevent osteoporosis, if you can.
Yeah, definitely.
So let me ask you this. You had mentioned the word corruption. Are there any other sort of like points within that topic that you kind of want to bring up when it comes to medications?
No, one thing that I've seen is we talked about the studies and how expensive they are. Well, there's drugs that are approved in Europe. They've gone through their clinical trials. They're approved. They have good safety data. If you bring those in the United States, they still have to go through the full trial. They start from scratch. This is obviously just for money. There's no other reason. The studies are done. The safety's proven. The results are proven. And they're probably better studies than we do here, honestly. And then they still have to pay hundreds of millions of dollars to get them through.
And they don't
that's
do
why
it.
drugs are so expensive.
Yeah.
Right? Is because it gets approved. You get a drug approved so that you can get it billed through insurance. That's the main goal. Insurance company pays for it. It's easy to get your money back because they set these super high prices. I don't know if you've seen recently, there's been a lot of people get arrested for Medicare fraud for skin grafts. They use them for wound care.
Miami's like the Medicare fraud capital of the world.
And I used to work with companies. We would use those grafts, and then I would see they did work, but there was much better ways to treat those wounds. Like we could take something as basic as amniotic fluid, right, and inject around the peripheral edge of that wound because wounds heal this way. They don't heal this way. And we could take a 0.5 milliliter, go around that wound, and within 2 weeks it was closed. They're billing hundreds of thousands of dollars for a single wound, and it might be closed. And if it's not, they have to wait a certain amount of time and then start over again. They don't let them keep going. If it's closing, you still have to wait a certain period before you can start it again. Medicare is killing themselves. If they would just let them heal the wound, it will be over with.
Yeah.
It saves so much money.
I had someone reach out to me, like asking if I wanted to open up a wound care clinic.
Yeah.
And I was
They
like,
make money.
that's going to be a
That's
hard no.
That's bottom of my list.
Yeah, I was like, absolutely not.
And
He was really promoting the financial implications, and I was like, that's a hard stop.
I mean, that's not a big thing here. I don't think. I don't know. Is it
It's
in
huge.
Houston?
It's huge.
It's really.
Yeah,
See, that's
yeah.
I don't.
Yeah.
I just don't come in contact with that.
We could have
All my wounds
made
heal.
millions of dollars using those selling those things. And after a while of doing it, I realized that it just felt dirty, right? So it's like let's do something else. I didn't like playing with Medicare dollars. I didn't feel right about it. So that's why we moved to. Everything I do now is all cash pay.
Yeah.
If the patient wants to pay cash for it, they can get it.
Yeah.
It's not up to the insurance willing to pay for it or not. You know, we're not cheating the system. We're not doing anything. If you want to buy this, here it is.
Yeah.
You know.
But speaking of which, it is a kind of a thorn in my side that we will start a patient on some, let's say, testosterone, cypionate, and going along fine, no problems, very affordable. All of a sudden, my office gets an email or a message on my chart that says, would you please send my prescriptions to Walgreens? My insurance will pay for it. Well, we then have to go through a prior authorization to get that patient
painful.
covered.
Yeah.
The cost to me is much greater than the cost that patient's going to save because it's not that much of a savings for him. He still has a copay.
Yeah.
And we can get him this testosterone. It's so inexpensive, relatively speaking.
Yeah.
And yet, every day I get these text messages.
Well, I just tell patients I don't do prior auths for testosterone injections.
Yeah.
Because it could be $113 for a 3 to 6 month supply, depending on the dose.
Yeah, I'm going to have to start doing that and telling them that.
Not to change the subject too much, but that brings up we're going back to my background, the protein intake for muscle and everything. I was in college and I was doing health and human performance was my bachelor's, and the teacher was talking about protein intake. And I raised my hand and I was like, that's incorrect. That's not near enough protein. And we got into an argument in the class. So I didn't go back to her class. And then 2 weeks later.
You showed her.
Well, no. Here's
She's like, bye,
the
Felicia.
funny part about it is some other students in the class came to me like a week later. They found me somewhere on campus. They're like, hey, man, you got to come back to class. She wants to apologize to you.
No.
I'm
Did
serious.
you go back?
I did. I
Did
went
she
back.
apologize?
She did. Publicly in
nice.
front of the class.
Wow.
She said, look, here's the bottom line. This is what's in the textbook. This is what you're going to be tested on. But what he said is true. And my point was, everybody that takes those classes are athletes.
Yeah.
Like, we require more protein than this is telling you that you need. And that was my only point. And we became good friends after that.
Wow.
That's
You know?
nice.
Yeah, she would actually ask me questions about different things, But it's just knowing that what's written in the books is not always accurate. You need to dive into it more.
Especially if it's an old textbook.
Yeah.
Because
Well, it takes years to even get a textbook published. So by the time it's
Exactly.
published, it's like outdated.
And look how fast things change.
Yeah. Which is the nice thing about like podcasts is you can update the information in real time.
Yeah.
Yeah.
Well, you had brought up earlier how just evidence of using certain things over the years has proved to you that they work, and that's really the best evidence.
Yes.
If you eat more protein, your muscles recover faster. You get more muscle size. It works.
Actually, you feel better.
Yeah.
I don't think carbs make you feel good. They do at the moment you eat them, but then it's kind of.
Well, and you see, like, you have a very busy clinic, right? So if you compile, like, the experience that you've learned from your patients over the decades worth of your career, that's way more patients than any research study.
Yeah.
There's so much value in that. So
But it still helps to go back, and we do a lot of retrospective.
Yeah.
Because we've got such a huge database.
right. And we need the research, right? So we need, it's like the art of medicine is combining what does the research tell us? What do the guidelines tell us? What do our colleagues tell us? What do our patients tell us? And what does our personal experience tell us? And then we combine all of those factors and not just look at one research study.
Yeah.
That's what makes us incredible providers and educators.
Yeah.
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 And you have to be able to prove all these things,
Yeah.
right? So the studies are important, even if it's retrospective. Like, you go back and look, okay, we did this. Here's the outcome. You can prove that outcome. And now you can talk about it plainly in front of people. You know?
Yeah.
Otherwise, you're just giving them, hey, I think this is going to do this.
Yeah.
Right. And that's usually effective, but not always.
Yeah.
Depends on what's going on with the body.
Okay, so let's dive into peptides because you had mentioned that you painted this picture of this commercial
Wait,
for
can
a
we just go
bipolar.
back just one step backwards and say, so how did the thing start? How did you get into pharmaceutical, actually running a pharmacy, owning a pharmacy? How did that evolve?
So I actually had a booth set up at a bodybuilding show for my stem cell company. And a gentleman came up to me and he started talking to me and he told me, I'd gotten stem cells by this doctor in the Houston area. And I don't want to use the word stem cells, regenerative medicine, basically. And I told him, well, I supplied that for that doctor. So we got to talking and he told me he had a pharmacy and it was very small. And so he asked me to come in and kind of see if we wanted to partner up and build a bigger one. And so I started doing my research on that, brought in another partner of mine that that owned a retail pharmacy. So I knew he was familiar with the environment, and we just decided let's go into this. And when we started it, I know the GLP-1 craze is obviously huge. Well, that wasn't our intention going into this. Like, we named the pharmacy Optimal Balance because my goal was to be able to optimize and balance your hormones. That was my thought process. Like, that's what we wanted to focus on. Of course, by the time we were halfway through construction, we saw that the GLP-1 craze was crazy. So I started really diving off into learning about peptides, because semaglutide, tirzepatide, there are peptides,
Right.
And that's what got me into that, and just started branching off into everything else.
Yeah, that's interesting that the entree into peptides was the drug that everyone now is taking, right?
Yeah. And peptides have been around for years and years. I mean, semaglutide's been an approved drug for over 10 years, but it wasn't popular until people realized they could lose weight on it.
Yeah. Well, and the Kardashian thing.
Oh, I didn't know. What's the Kardashian? I didn't know anything about this.
Well, Kim Kardashian had some, like stuff online or whatever in the public saying, talking about Ozempic, and then people heard about it.
Interesting. I did not know that.
Yeah, I didn't either, actually. Yeah, I don't pay attention.
Maybe she'd be a spokesperson for the pharmacy.
Maybe so. Yeah.
So you had mentioned you were painting this picture of this commercial on this drug to treat, bipolar disorder. And, you said like basically listing all the side effects was basically took up the entire time of the commercial.
Yeah.
Right. So there are medications that we have that are FDA approved for patients that have a long list of side effects where they could really hurt someone. A lot of people get concerned about peptides because they're concerned about safety. That's my biggest concern, is safety. What do people need to know about safety of peptides?
Well, peptides they're very basic amino acid chains. Like we discussed earlier, everything in your body functions off of protein signaling. Your cells receive protein signaling. They create what we call an endosome inside the cell that creates all the mRNA, microRNA, messenger RNA, and it expresses it out into the environment. That goes to another cell, communicates. That is how the cells work. So when that's happening, it's sending out peptides. Peptides as well, not just an exosome, so to speak. There's other extracellular matrix that has these peptides in it. One that we find a lot in just natural production of cells is LL37, which is antimicrobial, right? It kills viruses, bacteria, and fungus. So everything in your body functions off of peptide signaling at the very basic point of it. And so as we age, we have less of these signals. As we age, we have less stem cells in our body. This is why we see, as we age, we get collagen reduction in our face, we get wrinkles. It's because we have less cells that are able to produce those hormones and functions. And so all we're doing with peptides is we're now basically I don't want to use the word anti-aging or reversing age, but you're basically giving your body the signal that it used to get when it was younger. Like a big one, it's not a peptide, but people kind of categorize it that way as NAD. As we age, we have less NAD, less energy, less focus, less brain cognition. You supplement someone that's older with NAD, immediately they have better energy, better focus. It's because they're lacking those nutrients. They're lacking those signal pathways. So we're not giving them a drug that has all these other mechanisms of actions. They have a very specific thing that they can do, and that's all they can do. They're not going to signal all this other stuff. It's very, very basic signaling in the body. And that's why it's safe. All it's doing is doing a natural, what your body naturally does every day. We're just turning it on, maybe amplifying it a little bit.
Are all peptides naturally occurring, or are some synthesized de novo?
There's a lot of that are synthesized.
Like because I looked up some of them and it was amazing. Like, some come from the placenta. They're extracted and purified from the placenta. Others are from the gastric secretion, BPC, which is very widely used right now as an anti-inflammatory, and the people my patients love it.
Yeah.
And I think its origin is a gastric secretion.
It is. Yeah.
So I just wondered what percentage are naturally occurring.
I think the original layout of these amino acids into these peptides is all naturally occurring. They know, because what they need to do is they need to figure out what a range of peptides do I need, or amino acids do I need to have to create this signal.
Right.
So if they found that signal within the body somewhere, like insulin's a peptide, right? These are all these things are peptides. People don't really realize they are.
Yeah. So a peptide is actually a protein hormone, as opposed to the testosterone derivatives, which are steroid hormones.
Right.
And the peptide hormones, if I'm correct, stimulate receptors on the cell wall, whereas the steroid hormones are fat soluble, but go into the cell and actually work more in the nucleus. And that's a big difference between these.
Well, you do have some peptides like MOTC, SS31 that affect the mitochondria of the cell.
Right.
They make the cell produce more ATP, which gives you more energy and ability to function through physical activity.
But what I like about their pharmacy, Optimum Balance, is my new order sheet, they've actually named some of the peptides as to what it does. Which makes it much easier to explain to patients.
Yeah.
And it also reminds the doctor, I need something for this function. Well, look, this is what the recovery blend.
Yeah.
They have a recovery blend, which has BPC and several other things, but it's all in one checkbox for me. So I don't have to go and pick it up throughout the whole menu of things they produce.
Yeah. So Larry,
which I like.
Larry, let me ask you, in your clinical experience, because how long have you been prescribing these peptides for?
I don't know, 3 to 5 years, maybe.
So you would you say that you
then
have?
we go back to I guess 3 to 5 years.
Okay. So do you think would you say you have hundreds of patients on these peptides?
Yes.
Have you seen a side effect from these peptides that concerns you?
The only side effect I've ever seen is something at the injection site from an allergy.
Yeah.
I have never had a systemic problem.
Yeah.
What are the systemic problems
what's the worst
with
that could
peptides?
happen?
Yeah.
What's the worst case scenario?
Thing that we've ever seen is, like you explained, is site injection reaction. But there's one specific one we see with some of the growth hormone-inducing peptides where a patient will be taking it with no issues, and then all of a sudden they'll inject themselves one sub-Q area, it gets really swollen, and then all the other spots they've ever injected themselves react. So we know it's an immune response. It's not necessarily an allergy in the same, there's maybe some histamine reactions there, but it's not, it's because the immune system is just freaking out.
So it's not going to cause anaphylaxis.
Absolutely not. No.
But are there any peptides with specific blood pressure issues or, I know that the, one of them causes water, the ibutamorin, which is not a peptide.
Right.
But it's on,
It's in the peptide category, right?
So you have to be careful when you talk about these products and use the umbrella peptides. They're not all peptides.
Right.
They're small molecules, but they're not all peptides.
And the reason that one gives you so much water gain is because it affects your hormones. It affects your growth hormone.
Yeah.
That one, I did a lot of research on. They use that one a lot with children with growth hormone deficiencies and had some of the best growth hormone data that I saw out of any of the products. And it's an oral version, but it also affects your ghrelin, which makes you very hungry and insatiable.
So that's why I use it. I use it a lot of time for people who are trying to get bigger.
Yeah.
Because it makes them eat.
Yeah, which is interesting because I think so many people are focused on, people who are carrying excess weight and trying to lose weight.
Yeah.
But for people that want to gain weight, it's a full-time job.
It's hard.
Yeah.
It's hard all because you get satiated.
Yeah.
And you still need more calories because you're trying to grow.
Yeah.
And that's why I like the ibutamorin.
Yeah.
I use a lot of that, I think.
I wish it was around when I was competing in bodybuilding, honestly, right? Even when you're dieting for a show, you have limited calories, but you have to eat so much protein. It's just hard. You finish eating a meal and it feels like you're about to start eating another one.
Right.
These kind of supplements
kind of are.
Yeah.
Yeah, basically.
But even for people who are just trying to gain some muscle mass who aren't, an elite athlete, it's, the typical recommendation would be a gram of protein per ideal pound of body weight. So that means I need over 100 grams of protein in a day. I mean, that's even hard to get that amount of protein.
I suggest to people that if you're trying to gain muscle, obviously eat as much protein as you can, but supplement with protein shakes.
Yeah.
Fit them in where you can in between your meals. Most people have regular jobs these days, right? So you can't just go eat whenever you want to, but you have a protein shake, you can get it in. And that's the biggest thing with the GLP-1s is you see so many of these ladies and men, they lose so much muscle. Well, people always think, these GLP-1s are making my body lose muscle. There's actually things in there that protect your body from losing muscle, right? And we're not talking about the new one that's not approved yet. We're talking about semaglutide and tirzepatide. But the problem is when you reduce your calories that much, and also if semaglutide specifically makes you more nauseous than tirzepatide. When you're nauseous, you don't feel good. What do you think about eating? It's not a chicken breast and rice. It's something terrible, right? That's tastes good that you can put down. And so people are eating bad foods. And so I just tell everybody, look, if you're going to do these, you need to get your protein up. Yeah. That's bottom line. I don't care what else you do. You have to eat enough protein.
Well, Amy, you've shown that in your practice that you can help people not lose weight.
When we optimize their hormones, they stimulate their muscle. and they eat enough protein, then they can have more muscle at, when they're at their goal than when they started. But you have to have 3 of the 3. You can't have 2 of the 3. And the first thing that they eat off their plate has to be their protein. You can't start with the bread. You eat the protein first. If you're still hungry, then you can go to the vegetables and then you go, to like the starchy item. So going back to your point about the side effects, that was a profound comment that you said.
What was my comment?
Is you've treated hundreds of patients with peptides, and the only thing that you've seen is an injection site reaction.
Right.
Think about the medications that we use that are FDA approved. Would you say that side effects or more severe side effects with some of those medications are more concerning than with peptides?
Yes.
I think that's profound.
Yeah.
And that goes on to what you were saying about these commercials, right?
Yeah.
And so that safety thing is very important. Now, I've had some patients, they've been on BPC and other peptides, and they say, it's amazing. And other patients that say, it did nothing for me. Okay, so efficacy, it's going to work in some people, it's not going to work in others.
As all the FDA approved drugs.
Exactly. But if
Sometimes
it's
they don't
safe, that is huge. But I want to dive deep into that a little bit more, because from a healthcare provider's perspective, I'm interested in offering these peptides to my patients for the reasons that we've discussed. But how do I know if they're being sourced correctly? How do I know that they're not going to be contaminated?
Right.
I want to talk about that, but I also want to talk about the whole legal aspect of us writing.
Yeah.
So go,
we'll
let's
go
go to
into
that.
contamination and stuff
Yeah.
first. So when we opened this up, we were kind of naive to what it was, right? Like where to source them from. And you kind of look at these vendors that sell it here and figure it out. Well, real quick, I thought, let me just look at a Google map search of their manufacturing facilities for one of the largest peptide offerings in the country. And so I looked it up, and all of their locations they had listed as their manufacturing facilities were not manufacturing facilities. So I called them and I said, what is this?
Like, what were they?
They would just look like abandoned structures. Now, it's Google Maps. They could have been older images or whatever. But I told him, I was like, I'm not going to use your product until you can prove to me that these are actual facilities. And they didn't. And so I didn't use them anymore, right? They were not
Were
only
they
were they
pass-throughs, or were they non-existent companies?
I'm not sure what they were doing. I think they may have just had them listed wrong, right? Like old addresses. I don't know how long that company's been in business.
Yeah.
You know,
But where do you think they were manufacturing their product? You don't know. That's the problem.
People always, this is the funniest part about it, is people go, well, I don't want anything from China.
Yeah.
Well, it's all from China, right? China, India, and Europe. That's where they're all done.
Yeah.
If you get peptides right now in the current market that are manufactured in the United States, they're not the same quality. Honestly, they're considered research grade only.
But I think you have to emphasize the fact that all the drugs we get, not all, huge number of drugs that we get are coming from China, the same places. It's not unique to peptides.
It's because they can make them cheaper, right?
Yeah.
They have the manufacturing facilities. They have the cheap labor. That's why they make them there.
So tell
Everybody
me
else
something
wants to say.
that's important, and that is, I've been told that the places we get our raw materials from in the United States have to come from FDA approved source facilities in China and India. These are not, is that correct?
That is correct.
These are not like random companies. These are companies that the FDA says they are approved. And if that's the case, what is...
inspect them for that.
Yeah.
They got to make sure they inspect them to make sure that their safety techniques, all their SOPs are correct for the safety of the product, and to make sure they're actually producing what they say they're producing. And so what we use for us currently, I can't speak to any other pharmacy. The vendors we work with, they have a team that actually goes into these facilities, goes into China. They go look at all these facilities. They inspect them personally, and they are FDA approved facilities. There's a new term called the green list, right? If you're gonna import tirzepatide or semaglutide, it has to be from one of those facilities, or it can't get into the country anymore. I'm sure things get by, right? There was a time, probably 2 years ago, where you couldn't get semaglutide. It was on back order, period, everywhere in the world. And people started using semaglutide salts. And I had providers call me and they're like, hey, why can't you make this? Other companies are doing it. And I said, I refuse to do it because it's not the same product. It's not FDA approved. I just won't do it.
Yeah.
Well, they're doing it. I'm going to go to them. I said, you will get in trouble for writing these prescriptions. And 2 weeks later, almost every single one of them called me back and they're like, you were right. They didn't get in trouble, but they realized, they did their own research and realized that I wasn't trying to deter them from buying something from somewhere. I was trying to protect them.
See, the whole thing...
I don't care about anything else but protecting people. If you do the right thing, you're going to make the money that you need to make, right? It's not about making the money. It's about protecting people, providing this for the patients, and all that other stuff will come.
Yeah.
It's hard for me to wrap my head around this FDA-approved facilities in China and India. I mean, how in the world did that get started? I mean, what branch of the FDA does it? Do you ever hear anything about that?
No, when we get RFK on our podcast, then we'll have to ask him.
Yeah, he's coming. Not.
Okay, so you
we can get 'em on
do
here.
your due diligence when it comes to these manufacturing facilities.
Yeah, and then we get the COAs from them. It shows if there's any contaminants in there, the purity of the product. All of these things have to be in place.
Yeah.
We actually hired a in-house compliance officer who was ex-state board inspector, so she looks at everything. She knows what is required by a pharmacy in Texas.
Yeah.
In other states as well, but she was a Texas board certified inspector. So we basically we did this early on. You know, we've only been in existence for a little over 2 years, but I made sure that everything we did was compliant and safe. And so we paid the extra money for her to be in house. Most people don't do that. Everything that we do, we hire people that are smarter than us in certain fields that protect us and protect our patients. I know there's people out there, there's other pharmacies, compounding pharmacies that are producing products that they shouldn't be doing, right? And it's not that they're not safe or anything like that. It's just they're still in clinical trials. And when a product's in clinical trials, you shouldn't touch it.
Yeah, retatrutide, right?
Yeah.
We both have so many patients that are on that
They're all on
medication.
it.
Yeah.
From the
reason
web.
I would tell people not to take that is because they're actually, the reason it's not out yet is because they were experiencing cardiovascular events.
You had mentioned that.
Yeah.
Yeah.
Yeah, so it was supposed to be released last year.
Yeah.
And now it's pushed to either late 2026 or early 27 because they're having cardiovascular issues. And I talked to people that have taken it. I was just at A4M in Vegas with the hugest longevity conference in the world. So I talked to a lot of providers, and they're like, yeah, I took it. I hated it. My heart was racing a lot. I'm like, well, that's not good. Like, you shouldn't be a 120-pound female with a racing heart rate just because you want to lose some weight. It's ridiculous. You need to understand what it's going to do to you long term before you put it in your body. And we don't know that yet.
Wouldn't it
And
be
so we don't
interesting
carry
to
it.
know how much retatrutide is being sold in the United States as we speak?
Yeah.
Because, I mean, your sister was talking about a patient in Florida.
Who's doing great. But she's like, I want to be on the triple agonist. And she's like, what does that mean to you?
There's a ton of people taking it, right? And it all
But we
became
just know,
popular
but we're
online.
in just here. What is going on? Is this throughout the United States in terms
Oh,
of
yeah.
the phenomena?
Oh, yeah.
But what other drug can you remember that people were taking across the United States that hasn't even been
That's still in
released
clinical
by
trials.
the FDA yet? I can't think of anything.
No, not a single thing. And I guess the technology advancements make everything more available, right?
But it's the social media.
Yeah, yeah.
Because
Yeah,
that's how
exactly. That's what
people
I mean,
find
yeah.
out
Yeah,
about
it spreads
all
like
of this. You
wildfire.
know, they're advertising. These companies are advertising. You can get the retatrutide, and they're buying it online.
Yeah.
If it's real, how do they even know it's real?
They don't.
They don't.
They don't. No. That's my biggest issue is with this environment now is social media, YouTube. There's so many people that go out there that are doctors or PhDs, a lot of chiropractors that they start promoting a certain product for a certain thing, and they'll say all these just crazy stuff. If you do any bit of research, you can disprove everything they're saying.
Yeah.
But people are doing it.
Yes.
But those people are not only doing it, they're telling their friends about it, right? And so there's a lot of people out there that have become really, really famous online. What's the guy that made the Bulletproof coffee? Dave Asprey. If you talk to that guy now and see what he's talking about, it is insane. Like, and people are still following him. It's crazy. There's no evidence of what they're talking about.
But then you
And they
look
still do it.
you look at this stuff being sold online, right?
Yeah.
And then you have Hims.
Yeah.
And nobody says anything bad about Hims. It's the same thing. They're selling it online without a real doctor. Well,
Yeah.
they say, but
Yeah.
I mean,
Yeah.
not a face-to-face doctor.
So let me ask you this. What's the difference? Because I have so many patients that tell me, okay, I want this peptide. I heard that I could get it from this pharmacy. Can you send the script to this pharmacy? Right. And it's like an online storefront. So what's the difference between like a pharmacy like yours, which is a compounding pharmacy, and some of these just companies that have websites online that are just selling these medications like candy?
Well, they're not pharmacies.
Yeah.
Right. We don't even know if they're labs.
Yeah.
Right. We don't know anything about them. A lot of times you'll see online, they'll put up, we tested this product at this lab, and they flash it up on the screen. Well, I froze it the other day, pulled the lab up. It doesn't exist.
Oh, God.
Right. So they're testing. I can make a piece of paper and show you the testing is amazing.
Yeah.
Right. But you need to have the testing done from like a third party, legitimate testing lab.
Right. So to give
We
you an
use
example
Eagle
of what they
Yeah.
do, I wanted to get, I read some reviews and some research on kisspeptin, which is used for libido, which you and I have discussed. It's a big problem. We don't have a good treatment for men who have issues
Yeah.
with anejaculation, orgasm, things related to sexual arousal. And the Kisspeptin stuff looked good, and they had it. And I called and I said, listen, I want to order some Kisspeptin. Well, we're all out. I said, can you get some more? They said, yeah, we can get it. So they get the Kisspeptin raw material. And I think I spoke to you, and you said it's still in testing. So they have to quarantine their stuff until a third party tests it before they can even make it.
Yeah.
I mean, and I think that due diligence is appreciated.
That's huge. Third party testing is huge.
So the testing that we do for our products is what they call a method suitability test first. That is to find the method in which to test it to prove that it's sterile, because every drug is different. Some we can do a scan RDI, which goes through a machine. 24 hours later, it tells you it's sterile. Then sometimes you have to do a direct inoculation. You actually put the pathogens in there and let it culture for 7 days. There's a filtration. There's a medium test in there. There's all these different tests that you can use. So to identify which is the proper test to be able to test for sterility. That's the biggest thing, because I asked them, I went to the lab and I asked them, we had this product that wouldn't pass because of these 2 pathogens. And I said, explain it to me. And they said, we can't get these 2 pathogens to grow in your product. And I said, so it's sterile. And they laughed and they're like, yeah, technically it is, but we can't put our name on it that it is sterile because it doesn't follow this pathway, whatever their protocols are, right? Which is frustrating, but at the same time, I appreciate it because I know that when I get my products out, they're going to be sterile.
But how about
sterility, endotoxin? We test for potency.
But how about testing for purity? How is that done? Because I know you do that.
Yeah, we do. We test for the potency, essentially. Purity is, so if a product comes to us, it needs to be, between 95 and 99% potency. Nothing rarely is 100% potency. And then we make it needs to have that same number when it comes out. And so, the regulations are, it has to be between 90 and 110%. That's our range we have to be.
How can I get 110%?
You put too much in there.
Oh, okay.
Yeah. So, which is not really a big deal unless you're talking about something that you could overdose on,
Right.
like even vitamin D.
Yeah.
Right? We had a batch came back at 115%, and we trashed it because I can't. If I tell all the doctors out there this is 115% potency, I can't change the label because that's not what it is, right? So I have to just get rid of it. It's not worth giving it to somebody that. Patients will always take more than they should. Not always, but there's a lot of people that will, right?
If they can.
Yeah, and vitamin D can be a problem.
And if it's too high already, then what it is, they think they're taking more, but they're taking way more. It can hurt somebody, right? And so we have to make sure we fall in that range. And I'd like to keep it at as 100 as best we can, right? Sometimes it comes back low, and we have to figure out why. And sometimes it's because that peptide is light sensitive. Like methylcobalamin, which is not a peptide, it's B12, right? It's extremely light sensitive. When I get it into the pharmacy, we wrap it in tinfoil to block it from the light. When they go to make it, in the thing, we actually kill the lights. We take it out, they mix it, blend it, do all that, and then when they're filtering it out, we have it in a what do you call it? A beaker that has tinfoil over it, with just enough of a hole to get a hose through there to pump it out. If you don't do that, your potency will be less. It's very, very sensitive. And so you have to know all these things. If you're not doing all the potency testing, you're not doing all the sterility, endotoxin testing, you really don't know what you're getting. And so we have that data, and we provide it to our providers if they request it, so they can see that we've actually gone through this and make sure it's there. Yeah.
I love that. I love hearing all of the technicalities behind this. So I'm going to ask you both a question here. I want to know, what are the most popular peptides that people are...
I was going to ask
And then I want to know what you're prescribing.
I don't know what my list, but I was going to ask you for the 10 most popular. What is the most frequent prescription you're filling right now?
BPC, right?
Of the peptides,
Yeah, the BPC 157 is the most by far. But it's not just the BPC by itself. Like you mentioned earlier, the recovery blend. It has BPC 157, TB500, KPB, and GHKCU. They were all in their own right regenerative, we can say, right? Recovery type. Some are anti-inflammatory. Some are immune modulating. You have all these different things. Some are collagen producing. And so you blend them all together, and they're synergistic, and they work really well.
No, is that the one that people call glow? Have you heard that term?
Yeah. There's the glow.
But what is glow?
There's the glow and there's the clo, which is KLOW.
Is this the glow?
It's similar, right?
Do you make something called? You don't have a product called glow.
No.
But what is it?
That's just a kitschy name for it, right?
For the same thing?
Basically.
Yeah.
But what I see a lot of times, the ones that are marketing it that way are the research companies, right?
Yeah.
And the Clo or the Glow, I can't remember which one it is. The copper peptide in there, the GHKCU, is 50 milligrams per milliliter. If you were to inject that daily, like we recommend, you would get copper toxicity.
Yeah.
Ours is not near that high. It's 1/5 that dose. And also, if you get a copper peptide product and it's not blue, it's fake. Copper peptide is always blue. And I see these research companies, people bring them to me. What do you think about this? I'm like, it's clear, it's fake. You're not getting what you think you are.
Yeah.
And we use those kind of stuff in topical applications as well to produce collagen in the face. So
this is
what
really
is your
interesting.
topical? I didn't know you had that. What's a topical collagen?
so the GHKCU actually works really well.
I thought it was
topically.
injectable, but you have
It is injectable, right? But it helps produce collagen. So if you put it on the face,
But you have a topical?
we do. We just came out with the
let me
topical.
tell
Add
you-
that to the list.
Let me tell you one of the problems with the company.
Okay.
Is that they don't have sales reps.
We have a ton of sales reps.
Well, I don't have a sales rep. Who's my sales rep?
It was Kyle, right? He's still your sales rep technically.
I've seen him 3 times this year.
Yeah.
But that's how companies grow.
Yeah.
They grow by having sales reps, especially, and I think that the philosophy is, well, this guy writes so much. We don't have to send our sales rep there. But the problem is, as you get new products, if we don't know about them, we're not going to write for them. So we had to organize this webcast, for me to find out that you've got topical GHK.
Well, we haven't released it.
Now he's backpedaling.
No, we haven't released it yet. Like it's been formulated. We have our wonderful girls in the back that do all of our non-sterile protocols, and they've just been making stuff, researching, making stuff, and I found an additional peptide to add to the cream that she'd already developed, which is SNAP8 is another peptide. It relaxes the muscles in the face, so it works similar
So
to
they droop.
No, it works sort of Botox, right? And so, but it's not a neurotoxin, so you don't have that like long-term issues. But it also is collagen producing.
I just want to tell you
we're
that
gonna have both
Amy
of them.
tries a lot of the stuff that we talk about here.
I'll send you
of
some.
course.
You can try it out.
That'd be amazing.
Yeah.
Thank you. I appreciate you
Do
in
you?
advance. I do. Because if I'm not going to try it, why would I expect my patients to?
I'm the same way.
It's not like I'm going to try a cancer drug just for shits and giggles, But if there's a therapy that I think could provide patients benefit that I can get and try, that's just one other thing I can add to the conversation I have with my
Yeah,
patients.
that's very admirable because you can
Thank
see
you. I'm
that.
taking one for the team.
She is, and she can tell people this. It really works.
And I think some people think that's unprofessional. My patients love when I give them the personal experience.
I like
Always.
it. We all like
We
it.
all like it.
You almost have to really,
Yeah.
like to be able to explain to people what they're going to feel,
Yeah.
what their results they're going to get. And I've tried everything that we make, and people always ask me, "What peptides are you on?"
Yeah.
Well, I'm only at one at a time.
Yeah.
Because I'm seeing what it does. I
Yeah.
have to give it time to do that. There's been peptides that we've carried that I removed from our list because it didn't do anything to me.
Yeah.
Yeah, but is that a fair test in that not everybody
Right.
is going
No,
to
exactly.
respond
Yeah.
the same to these peptides or even hormones?
Yeah, no, you're exactly right. Everybody's biology is different.
Right.
You can give somebody something, they're going to see remarkable results. And like you mentioned earlier, some people get numb.
Yeah.
Right. But that's all about where their body is in their hormone levels, their health, cellular health. If everyone is in the same boat there as far as being healthy, they're going to see the same results.
Yeah.
Unfortunately, nobody is.
Yeah.
Right. And everybody's genetics are different as well. Your ability to receptor sites and different things. You see pro bodybuilders, how big they are. People think they're taking just stupid amounts of drugs, which they are taking a lot. But those guys, they just have better receptor sites. They absorb
But they are
those hormones
so
better.
careful about their diet.
Oh,
so
yeah.
careful, and they are so into working out. I mean, some of them don't do anything else but train. That's all they do.
They train,
and then
they eat, they sleep.
So I know if I don't know how many people would not respond that way, given all these criteria of eating and sleeping and lifting weights. I mean, unfortunately, most of us have to earn a living.
Yeah.
Right.
Exactly.
You mentioned another interesting concept, which is a peptide stack. And I think that's why maybe some people don't notice benefit because maybe BPC 157 by itself is insufficient. And what maybe you've told me or Alex Tatum is they like the combination of TB 500 with BPC 157. So sometimes
That's the only way you can get it from them right now. It's pre-mixed.
So sometimes
right?
just when you're doing one agent at a time, sometimes it's good to know whether or not that one agent is helpful, but sometimes that one agent is not going to actually get you the results.
Right.
Yeah.
Exactly. It'll address one part of the problem, but there's other problems on the side.
That's where
that you have to
reps
address.
are so important.
Yeah.
Because they come with the knowledge that you don't have.
Right. Because it would take me
Theoretically.
10 years of clinical experience to get this information versus I want someone like you to say, hey, I've done this for the last year. This is what I've found.
Now,
Okay, great.
Now, if they had a great newsletter that went out to all the people who prescribe, new drug of the month, new insights, then everybody would be on the same page. And that would be much more cost effective than sending reps to everybody.
I agree.
But you've got to get the information out to the doctors, or the doctors can't write the prescriptions.
Right. And we are coming up with a newsletter soon. When we opened, our job was to make sure everything was done correctly and all that. And we grew at a rate that we couldn't imagine. Right. And so we're constantly playing catch up. And we do a good job of it. But as far as, like you talk about, the marketing to the physicians and all that, we're depending on the reps to go out there. But they don't have the same mindset that we do all the time, right? But some of them do. So we have some reps that we work with now that just created a newsletter and sent it to me. They're like, "Do you approve this? I'm going to send it to my doctors." And I was like, "Yeah, this is amazing." It's not something I thought about. That's not my mindset. My mindset is to make sure this is good and not put out marketing material, right? But it's important to be able to educate people because if you meet with a rep, honestly, like, how much time do you have to spend with them? Not very much.
Right. Give me
Sometimes
something. I like when they give me something, like not a cookie.
Right. Material to read, right?
But something to read.
Yeah.
And plus, it gives credibility to your institution, because it's telling us that you are taking the time to educate the doctors who you work with. I really like that.
Yeah. So what else is a popular peptide?
Yeah. Will you write this down? You're writing.
I'm taking a mental note.
So we do one, we call it the fat burner blend. So I think part of the popularity is like the name, honestly, but it identifies what it does, right? And so it's AOD, 9624, MOTC, tesmorelin, and ipamorelin. And so it's 3 different growth hormone inducing peptides at moderate doses that work synergistically, but those specifically help with reduction of body fat in the abdominal area. One's visceral, and one's sub-Q, right? And so you'll see a change there. The AOD, you need to be on it for quite some time to get the best results from it, where the tesmorelin works pretty quickly. And none of these are instant, right? These are peptides, they're signals telling your body what to do. You have to give them generally several months to see long-term good outcomes from them.
And I've seen that with GLPs. I've seen that the people don't really realize the benefit until 3 months. And then they'll tell us, I'm starting to lose weight.
And it's not even necessarily the number on the scale, but now there's cardiovascular, things, and with sleep apnea and so many other mechanisms that we haven't identified, that even if the number on the scale is stable, there are probably 50 other mechanisms by which we're not tracking.
And the problem with that data is like they've got it approved now for cardiovascular issues, right? It's not that it's making all that happen necessarily. It can be. But if you eat less food, you're taking less calories, your body functions better, you're going to give all that symptom relief. Inflammation in the body, if you're eating shitty foods all the time, you're going to have inflammation in your body. Your body, proper growth factors in the body cannot function in an inflamed environment. That's why you see type 2 diabetics not heal, because they're so inflamed that the growth factors can't close that wound and things like that. You have to be able to optimize the body. Number one, that's just what you have to do. And now I kind of got off a tangent. Forgot what were the original question.
I have another question. Yeah, go ahead.
No, you go ahead.
Well, I was going to say, a big concern with the GLP-1 medications for some people is, okay, if I'm on this medication, I'm going to have to be on it for the rest of my life. Is that the case with peptides, where you only get the benefit when you're on it? But let's say the person is eating well and they're exercising and they want to trim some visceral fat, so they take, the fat burner cocktail that you're talking about, and they're doing all the things, right? They take it for, let's say, 6 months and they stop. What happens?
Well, if they continue eating in a poor habit,
what if they continue eating in a great way?
Then they'll sustain that, right? What my goal is, or my hope is, for people that are doing peptide therapy, is to learn a new lifestyle, right? If you're taking these things, you're trying to improve your body, quit doing what you were doing that made your body dysfunctional. And when they start feeling better, they're going to start going down that pathway. You start feeling better, you're like, well, this made me feel better. It rewarded me. I'm going to keep doing it. That was my hope with the GLP-1s, is that people would learn new eating habits. The reality of it is, as soon as they get that satiation signal gone, they start eating again.
Yeah. Well, and a lot of people are never taught the foundations of nutrition or how to eat on those medications.
They don't. There's
so we don't have a lot of people like your sister in Houston.
Right.
I can tell you, we do not. Do you know who you can send somebody to who will talk about their nutrition and their gut health and their microbiome? Who do we have?
And minimize GI side effects while they're on GLP-1s.
I know probably one person.
Yeah.
Who? Oh, we don't tell me later. We don't want to say names, but seriously.
But are these peptides, GLP-1s are safe for people to be on long term? Are these peptides safe for people to be on long term? Do we know that?
They are, but we don't have super long term data, right? And so we always recommend, if you're going to do something, do it for a few months, take a break.
Yeah, I don't understand that with peptides. They are telling people 3 months on, 1 month off. And I don't know the why of that.
I don't honestly either, except for the fact that
Well, is it like folklore or something?
yeah, let's make sure we're not causing problems, I guess, is the idea of it.
Yeah.
Or just the receptors for those signals maybe get clogged up and they don't function as well.
We can saturate receptors, but it's not going to make them stop working. We do that with
but it's interesting
testosterone.
because we don't do that with
Anything.
other medications that we prescribe, right? We just put them on it and say,
For
okay,
instance,
you might be on this for the rest of your life.
A case in point is alfuzacin. Now, alfuzacin we give people to relax specifically the muscles in and around the prostate for men who have voiding dysfunction. If you miss one day of that drug, the symptoms come back. Yeah. Because it just works when you're taking it.
Right. And that's how these are. The peptides, I mean, they're amino acids, they're signaling mechanisms. They get used like that. Once it turns that signal on, it's gone.
Yeah, so if
these
you
don't stay in your body. They
So
don't cause
being the
deficiencies down
devil's
the road.
advocate, then the month you're off your BPC, everything's going to hurt.
It could, right? Well, hopefully, the goal is with BPC and TB500, things like that, is actually heal the injury.
Yeah.
Right? If we heal the injury, you don't need it.
Yeah, so that'd be interesting to see maybe.
Well, that's what I've heard from
prospectively.
patients, though. Like, I've heard patients say, I injured my shoulder. I took BPC 157, TB500. I feel great. And they got off of it. So they just take it when they need it for recovery.
Right.
Which I think that's the ideal medicine.
Right, and it's especially
That's the ideal scenario.
After surgery, like orthopedic surgery. I give a lot of BPC to my patients, and they just have to take it until they get better. But for people who use it for aches and pains and recovery from working out, I mean, they're always going to have aches and pains when they work out if they're working out hard. So I don't know whether, but I do cycle some of them off. It's kind of like out there in hyperspace. The patients know that the word on the street is, come off every once in a while.
Yeah, like you said, folklore, I think is kind of what it is. There's not enough data to show that you should come off of them. But if you have a good peptide that's doing the function it should get your body where it needs to be. Now, the ones that are losing fat and things like that, like the testosterone, that when you quit taking it, you're going to reduce that signal.
Unless you've changed your diet.
Unless you change your diet, right? I mean, you can take all the peptides in the world, and if you're still eating terrible, you're not going to see much results with it, period.
I think that's part of the
Let
problem.
me ask you something. Internally, in the pharmacy, do you think about which ones are FDA approved and which ones aren't? Does that enter into anything?
It doesn't to me.
Because tesamorelin was FDA approved for years. It came around because HIV patients in the early days of HIV would put on centripetal fat. So this was developed to help them lose, and FDA approved to lose centripetal fat. But then for some reason they withdrew it. I don't understand how that happens, actually.
Well, they pushed it into, they said it's a biologic, right? And so then it's on a different category altogether. It's just ways of regulating things to make more money, essentially. Right?
So follow the money, figure
Always
out
follow the money.
what company is selling what,
Yeah, exactly. We have clinical trials going on with our pure stem cell source we use with Dr. Gonzalez, who I mentioned earlier. And the amount of money and the amount of stuff they have to do to get through these trials, I mean, they have to be so careful. They can't say anything that's off brand. Like, basically, we'll go to conferences and people ask him questions, and he'll go grab me and pull me over and you say it.
Yeah.
Right.
Because that gets into the concept of like the legality.
Yeah.
Right. Where some patients will say we'll say to patients, well, it's not legal, so I can't do it. I've said that like countless times. Right. So is what we're talking about illegal?
No, that's the biggest thing is people say illegal. That's a criminal defense. That's jailable or ticketable offense is what illegal is. If someone's doing peptides and they explain to their patient that these are not FDA approved, they're technically considered research, right? If you explain that to the patient but then show them the data, this is what it did in this subset of patients. So I think it might help you, right? You're just explaining to them it's not FDA approved. It may or may not work. Give it a shot if you're willing to do it on your own. You make that decision. That's the compliant way to do any medicine, I think.
And I think I told you what I do. I have my patients sign an informed consent that talks about peptides and the FDA and that they understand they're not taking something that's FDA approved.
Yeah.
And they sign it and it gets scanned into their chart. So they know. They should know.
Yeah.
Are they understanding it? Who knows? But I think they are because it's pretty clear.
Have you ever had a patient say, oh, no, I'm not signing that consent?
Never.
Patients don't care.
I know.
I don't think they care.
No, they don't.
They've done the
I
research
care.
themselves.
Yeah.
They
I
want it.
care.
Yeah.
That's why I'm doing it.
Right.
I'm protecting my practice.
Right.
Yeah, of course. We always advise people if they want to have a informed consent to do so, right? It's your practice. You handle it the
And
way
there's
you
no
want.
reason not to.
Well, honestly, you're probably giving more education and informed consent when you actually talk about peptides than with any other medication we prescribe. It is so often as healthcare providers, we just say someone comes in with urinary dysfunction. We say, oh, I'm going to put you on Flomax. Here's a
we
medicine.
tell them nothing.
And we tell them, and we don't tell them about the
Well,
side
we tell them
effects.
they're going to lose their visible ejaculate.
Well, but I've had so many patients say, I was never told that information. I was never told I could have orthostatic hypotension. So I'm almost wondering in this scenario, it seems like we're educating patients on peptides because we're actually having informed consent.
Yeah.
Yeah. And also, the patients are really informing themselves.
Yeah.
When we opened this pharmacy, we noticed we would see, and specifically your practice, we would see this, because we had more visibility. We had less people coming in. We were tracking everything. And we would see a patient would get on a peptide. The next month, they were on 2 peptides. The next month, they were on 3 peptides. I guarantee you weren't in there marketing peptides. You would get them on a peptide, they would get the good results from it, and then they would go do their own research. And they would go to you and say, I want this peptide.
The other
right?
thing is, I don't like starting patients on more than one new drug, because if I start them on 2, I don't know which one's working.
Yeah.
Especially if they're in the same kind of arena.
Unless
for
it's
what
part
they
of
do.
like a stack, I guess, that he was talking about,
but,
right?
Yeah, but they come pre-blended.
Yeah.
But I'm talking about like I wouldn't, but just I don't like doing that with not the peptides, anything.
Yeah.
Yeah.
Well,
You
let
know,
me ask you
like
this.
if I'm going to start them on alfuzacin, I'm not going to start them on finasteride the
Right.
exact same time.
Yeah.
I want to let one work.
Yeah.
Yeah, people keep asking me to mix NAD with other compounds, and I refuse to do it because NAD can give you immediate negative side effects if it gets in your bloodstream too fast. And if that works for somebody, if they take it properly, that's great. But if they're taking this combination and they get these side effects, they assume that everything in there is causing these side effects,
it's
but
not.
it's just the NAD. So I don't make it because I don't want side effects to happen from something that's not.
Have you thought
side
about
effects.
infusion therapy in terms of something that you would make? Or does that require another type of pharmacy?
No, we're classified to be able to make all those things. We can make up to cancer drugs in our pharmacy. We have negative pressure, ventilated hoods that vent the chemicals out of the building. We can make anything in there we want to, except for biologics.
But infusions, you're not going there yet.
Not yet. It's just like what you're talking about for like.
Well, you
cancer
mentioned
treatments
NAD.
and-
No. I'm talking
NAD. Yeah, I mean,
vitamin C, high dose vitamin C.
yeah. We make the solutions that you can put into an IV bag.
Yeah.
But we don't pre-make the bags, and part of that is most of these combinations do put a vitamin C in there, which is ascorbic acid, and it will delineate the other vitamins if you combine them all into one bag. So regardless, we still have to ship the bag. It could have some solution mixed in there, like a Myers cocktail or something like that. Yeah. But then we have to ship the vitamin C separately. They would put that into the bag prior to infusion.
Right.
It's hard because if you make these bags, you can't make them ahead of time. Because once they're in that saline solution, they're going to lose potency over time. So we would have to make them to order, and it's just not feasible for us.
Well, you could have an infusion, an infusion, what do they call them? Center associated with your pharmacy, like some places do.
Yeah,
Is that big in Miami?
We work with a ton
the
of those.
infusion, people going for infusions. That's really big here. These very wealthy people go and they have everything infused.
Yeah, and you can use lower doses because it's going straight in the bloodstream. You know, a lot of our stuff we market as intramuscular injections, but it's sterile, safe to use in an IV as well.
So what are your top peptides that you're prescribing?
Certainly BPC, ibutamoren, MK677,
CJC ipamorelin.
tesamorelin, CJC for cutting and leaning.
IGF-1R3.
Yeah, for bulking I do IGF-LR3.
So it's very nuanced. So we have to educate ourselves because even if someone asks for a certain one, they may not understand exactly what that's for. And everything that you've discussed so far, it's kind of for sort of a similar patient that might be looking to enhance their performance, but it's very nuanced.
It is nuanced.
Yeah.
But I mean, I think what they're doing is helping because they're giving me names associated with the compounds. So if someone asks me something, I don't have to, I can even, show it to them. I don't like giving out my prescription things. Do you? What do you think? With everything on it.
We're actually making, it's made already. We have, for every peptide that we carry, it's going to have a lengthy thing describing what the possible benefits are. No, this will be for you to hand to your patients.
Oh, nice.
So they can take it home and read it, right?
How will I get that
Possible
if I don't
side
have a rep?
We'll email it to you. You print them off. No, we'll bring them to you.
When I need something, I call.
Yeah, you just go right up to the top.
I mean, I
think the problem is you're bypassing.
I don't have anybody. No, there's nobody for me to call right now.
Yeah, reps. we struggle with that, right? Getting them
But
in
you've
there.
been there. You know the whole rep
Yeah, I was a sales rep for
environment.
years.
Yeah.
You have to go back and talk to their doctor because guess what? Tomorrow, another pharmacist is going to come talk to you,
Yeah.
as you know, right?
As they have.
For years, right? And if you're not in there, building that relationship, that's what it's about. Building a relationship with the doctor, providing beneficial things like education. If you're not doing that, if you're just bringing donuts or whatever, who cares?
The donuts are good.
Yeah. But you have to be able to
But
go
they're
there and educate them.
sabotage.
Do you get that? Do you have reps bringing you like, well, you
Oh
and
my
your
God.
sister
No,
don't
but
eat
it's so
anything.
funny, and I always feel bad, but some of our colleagues, right, will send us gifts during the holiday
Yes.
time, and it's like this huge gift basket of processed foods. And I don't want to be rude and be like, do you not know what we do? But we don't really allow those foods in our office. We have events at our office quite frequently. And I asked my sister one time, like for our opening party, I was like, Michelle, do you think we should serve ice cream? And she was like, I cannot believe you asked me that question. Because we want to show people that you can entertain and still do it in a healthy way.
Yeah.
So what are you going to have at your, what did you have to eat at your
Oh, we
opening?
serve Mediterranean food.
Yeah.
Yeah. I mean, anti-inflammatory food. And there's really good food out
you
there.
just can eat so many beans, though.
No, it's good stuff. So, Larry, can you describe the typical patient that comes in to see you that you would consider putting on peptides? Because if someone comes in and they have low testosterone, are you addressing their testosterone first and then considering peptides?
Yeah, always.
Always.
Right now, we don't have anything peptide-wise that does anything with androgen receptors. Do we?
No.
So in order for me to give patients that type of a therapy, I have to go to steroids. And I would always use that therapy first. Again, I don't want to do two different things. We'll do that, see how they respond. And then if they still need other things to help maybe lean or to bulk or, with aches and pains or with their libido, I will then go to I'll add the peptides one by one. And again, it's nuanced.
Yeah.
I mean, you have to know what the peptides are expected to do so you can address their specific issues.
Yeah. You're truly practicing personalized medicine, but you're so ahead of your time. And you've been so ahead of your time probably your entire career with the
Right.
innovative therapies that you offer. And you've also sat as top dog of many very well-respected organizations. Do you get pushback from your colleagues about what you do?
Not yet.
Not yet.
I don't because
You've built a great reputation.
No, it's not just that.
Yeah.
But if I'm going to be in a situation where I'm speaking to an audience,
Yeah.
another group, I'm not going to go into areas that I think are fringy. I'm not going to. I'm going to just try to stay mainstream unless I'm asked specifically. Like for instance, at the sexual medicine side, I was asked to speak about peptides.
Yeah.
Which I did.
Yeah.
But I made sure they understood these are the peptides that are FDA approved. These are the ones that are not FDA approved. This is what's being asked for, what's being manufactured out there. So it was education, but it wasn't, this is what I'm going to do with Mr. X. I mean, that's my personal practice, which I don't like sharing. I mean,
Yeah, and to that point, I think the most important aspect of peptides and doctors prescribing them is that they should never say this peptide will do this, right? Like you can't give it an indication. It's going to treat this specific issue. Because now you're giving an indication that it was never proven to work for. As a provider, that's giving inaccurate information to your patient.
Yes, but if I give them BPC,
You explain to them-
I'm giving it to them because they're having issues with tissues.
With inflammation, right?
Yes.
So inflammation is not a diagnosis, right? But osteoarthritis is. So if you say it's going to help your osteoarthritis, it might, but you can't say that.
No, yeah.
So it's just kind of my
That's
overall.
that's
for
very
all the
nuanced in
clinicians-
terms of
All the
verbiage.
clinicians, that may see this is when you promote this to your patients, make sure that you're not telling them that it will cure or heal any indication that's not proven for. If it's FDA approved for something, have at it, right? But just to protect yourself, explain it to them what it does, how it can work, what we've seen happen, and leave it there.
Yeah.
And leave it to the patient to make that decision.
Yeah. Would you say that's your big message to potentially prescribing providers?
Yeah, absolutely. That's the main message.
That's the main message.
Yeah. We saw this years ago with stem cells. People were claiming all this stuff. And the FDA came down on a lot of people. Well, we realized the FDA wasn't coming down on the products. They were coming on the verbiage. That's what they care about. You cannot market or promote this in a way that's inaccurate from the data. And so as long as you're promoting what we've seen, and you can talk about other studies, right? But it's not FDA approved for that specific indication. But we know the mechanism of action can help that specific indication, right? It's going to help the causation of that indication. We're trying to resolve symptoms. We're not trying to cure the end point. which eventually will cure the endpoint. If you do it correctly, right?
But it's all about the verbiage.
It's all about how you say it.
The marketing.
Just don't.
Yeah.
'Cause some people are so uneducated. They say these things, but they actually don't know what they're saying. Right? It's important to be educated on it, because when you talk about it, these guys will just hear from somebody, oh, this will help with this, and they put it on their website, but they don't know what they're talking about. They don't know if it'll actually do that.
Yeah.
And it's dangerous, I think. So it's just important to be educated and find someone, take courses that'll educate you on Dr. Seeds, everybody in the industry that does peptides knows Dr. Seeds. He has a very good course.
I don't know Dr. Seeds.
You never heard of Dr. Seeds?
No, never.
Dr. Seed is like the #1 peptide guru in the country.
Where is he?
Maybe in the world. I'm not sure. He's actually an orthopedic surgeon.
Yeah.
That
See, there you go.
Does this, right? And
there's also an orthopedic surgeon out in some place in the periphery doing vasectomy reversals. So the business must not be good.
yeah. It's but he's been doing it for a long time. I mean, he's on tons of podcasts. You can listen to him, but he has a course that you can take. And he'll educate you on this, and it's much more comprehensive than some others that I've seen out there. So I would definitely use that one. It's not cheap, but it's worth the money.
Yeah. Rick, you're awesome.
Yes, and thank you so much for coming today. I mean, we know you have a lot of other things you could be doing, but thank you for spending time with us. We learned a lot.
It's an honor. I appreciate it. No,
Well,
I
thank you
respect
again.
both you guys, and I appreciate you inviting me here.
I'm so glad that you brought Rick onto our webcast today.
Yeah.
Because I always find it fascinating to get a look behind the scenes. There are so many pharmacies out there. And the biggest thing that we can do, I think, as healthcare providers is to find the good, trustworthy pharmacies. So the information I learned today from Rick, I am going to bring back to my patients immediately.
Yeah, I think that's one of the important things about the speakers that we get is we get take-home messages for ourselves. But I also think it was interesting to hear the fact that the materials that they use to make peptides comes from FDA-approved facilities. These are actually inspected sources of the raw material. And once they get it, they retest it here in Houston for the
Purity, safety.
Lack of pathogens, and have to maintain a certain level of purity, above 90%, above 95%. So that's very reassuring.
Yeah, he clarified a lot of the concerns that I had coming into today's webcast. So I'm excited because I'm going to start delving into the peptide space, because I think at least now I can offer my patients something that I know is going to be safe.
Yes.
So I appreciate your feedback on your clinical expertise as well.
Oh, of course. Anytime. Feel free to ask me anytime.
Okay, sounds good. Larry, what's the final F word for today's episode?
Okay, well, today the F word is pharmacy, but I know it doesn't begin with an F.
Okay, I'm glad you clarified.
I just want to make sure people know that I understand this.
Thank you for joining us today on fertility and other F words.
And don't forget to like, subscribe, and leave a comment.
Until next time.